Why is the mortality rate for COVID-19 lower in some countries? Singapore and Qatar stand out as two that have managed to keep deaths well down. What's exactly behind that? This is Inside Story. Hello and welcome to the programme. I'm Peter Dobby. As COVID-19 started to hit the world, many of us were concerned about whether we would become infected. Some said it's as bad as the flu. Others predicted worse. Then news about health systems being overwhelmed and bodies piling up started to emerge. That gave us a bleak picture. But it's not the picture everywhere. Mortality rates in Qatar and Singapore are below 0.1%, among the world's lowest. The Gulf nations' mortality rate is 0.07%, 12 deaths out of more than 16,000 cases. In Singapore, it's 0.093% of more than 19,000 infections. Experts say testing, the availability of hospital beds and population age are three critical factors. Yet, Singapore's outbreak is the biggest in Southeast Asia, and Qatar has the second highest number of cases in the Arab world, although the curve is beginning to flatten out.
Number of cases has gone up, but that's only natural, and I believe that actually it's a result of our very strong testing measures. So as you've seen, we are testing a lot in Qatar. So we've been testing approximately 40,000 per million. So that's quite significant. That's one of the highest rates of testing. And that reflects a true picture of what's happening in terms of infection rates. So the rates are not high. They're realistic. You will find that a lot of countries at the end of their pandemic will realize that their curve actually looks like ours. The fact that we are not peaking as aggressively as we could have is because we have flattened the curve.
OK, let's have a quick look now at COVID-19 mortality rates in other countries. Just behind Qatar and Singapore, Belarus, Saudi Arabia and the United Arab Emirates. Some nations with small outbreaks, such as Vietnam, haven't suffered a single death. On the flip side, Belgium has the highest per capita death rate in the world, and in Italy, it's estimated to be around 13%. The US leads the world in infections and deaths, with the virus killing 200 people per million. OK, there we are. Here we go. Let's introduce our panel today in Doha. Dr. Ali Omrani, a senior consultant in infectious diseases and head of research at the Communicable Disease Centre at the Hamad Medical Corporation. From Geneva, we have Dr. Annie Sparrow, Professor of Population Health Science and Policy at Mount Sinai Hospital, also an emergency and critical care physician. In Perth, Australia, we have Archie Clements, Professor of Infectious Disease at Curtin University in Perth. Welcome to you all. Dr. Omrani here in Doha, how have the two countries managed this?
I'm not quite sure whether you're referring specifically to the low mortality rates associated with COVID that Qatar has been able to maintain. I think this is largely the result of three things related to how Qatar was able to handle the epidemic so far. Primarily, there's a bit of luck there. The demographics of Qatar are such that the majority of the population are relatively young, relatively healthier, and with fewer comorbidities. And indeed, if you look at the statistics for those who had COVID in Qatar, you would find that nearly 70% are between those ages of 25 to 55 or thereabouts. Only 1% or so are above the age of 65. So having a healthier, younger population would certainly help. The second part is that Qatar has been very, very active in terms of case finding and testing, very aggressive, proactive case finding, contact tracing, screening activities. And that means that the background numbers, the denominator, as we would call it, is relatively close, hopefully, to the real numbers. And that means that when you look at proportions of deaths out of the totals, these come out as lower because we're able to identify more of those who have infections in the background. The third, I think, and that's also a very important point, is that Qatar has been able to expand its healthcare capacity fairly quickly. There's a lot of flexibility within the system, And that allowed it to open at least 2 new hospitals and dedicate those for COVID patients. And more importantly, it was able to more than double the critical care bed capacity, which means that we can look after a larger number of patients who are critically ill and hopefully help them survive through these illnesses. So I think using those 3 sort of key points are the main reasons why Qatar has managed to do what it's done so far.
OK, Dr. Annie Sparrow in Geneva, are the statistics reliable?
Without being able to independently verify the numbers, and some countries are very good at allowing independent verification by WHO, for instance, others aren't, such as China. When China recently revised its death rate in numbers in Wuhan, there was absolutely no change in methodology. So sometimes we simply don't know how good the numbers are, and nor do we know not only how much testing has been done in the US. Even Trump doesn't seem to like testing because it will put the numbers up, for example. But we don't know what goes on the death certificate. So sometimes, in Syria, for example, the cause of death is always cardiorespiratory failure. Sure enough, your heart stops when you die, but that's different from putting COVID as the reason why your heart stopped. So it's a very good question, and one that we always need to chase up on, particularly also because the death rate and the numbers always lag behind the number of infections. You can spend 3 weeks on a ventilator and then die, or then survive only to become a cardiac cripple and then die after that. So sometimes there is a real lag in the mortality reporting. OK, Professor Clements there in Perth in Australia. Is it as simple as realising and accepting we're talking about 2 fabulously wealthy countries, Singapore and Qatar, so as well as the flexibility, they have the money, they can afford test kits, they can afford all the gear, they can afford to import it very quickly?
Well, I do think that's part of the story, but I don't think that's the whole story. I mean, of course, we've seen high mortality rates in very rich European countries, for example. So I think I actually agree with Dr. Amani, his assessment. I think there is a degree of good fortune. I think the youthful population, the large number of migrant workers in both Singapore and Qatar that tend to be younger, healthier people, in contrast to, for example, countries like Italy and Spain, where you have quite a different demographic. You have a high proportion of older people. I think it's also the way that older people are cohorted together in some of those northern countries and also in Australia in aged care facilities. If you contrast Singapore, where you're getting large numbers of cases in young migrant workers, with Spain and Italy, where you're getting large numbers of cases in people in aged care facilities, I think that goes part of the way to explaining the differences in mortality rate. I also think in European countries, what happened is that the number of cases went beyond a tipping point at which the health system was no longer able to cope, and so individuals were no longer getting essential treatment that would effectively save their lives. And in countries like Singapore, Qatar, Australia, the health system hasn't been overwhelmed, and therefore people have been able to access life-saving treatment. I think those are some of the issues. And then I think there are a whole bunch of other potentially more complex issues in relation to differences in immunological profiles between regions, different histories of exposure to viruses, potentially genetic differences in populations, and of course, importantly, socioeconomic differences where the general population may be more or less health literate and may be more or less likely to access healthcare in a timely way, maybe more or less likely to undertake proper hygiene behaviours. So I think it is a very complex picture and very difficult to boil down to one particular factor. OK. Annie Sparrow in Geneva, could part of it be as well that whilst we're talking about very small, very wealthy countries, Singapore and Qatar, we're also talking about a very high number of migrant workers, whether they're blue collar or white collar, you are tested. So the starting point is one of physical wellness and well-being even before you get the residency permit, because if you don't pass the medical, you don't get the residency permit. So, the median age, say in Qatar, for contracting the coronavirus, I think it's 32. Singapore, it's more like 41 or 42. But the starting point is those individuals, predominantly men, are quite fit and healthy anyway. Absolutely. That's a very important point, because
when you're testing asymptomatic individuals for that reason, because you needed to do it for a visa residency, then you're going to pick up all the asymptomatic cases, which is not necessarily done in other countries, which are, especially if they're at a different stage of the epidemic, they're dealing with this catastrophic rapid influx of patients, as we've seen in places like Italy, where only the sick people present. If you're asymptomatic, you don't even think you're sick, or even if you think you might be, if you're not that sick, you're basically told to stay at home, as you are in Britain. So you automatically, you're capturing all the cases, which is great. We have a good idea of what the numbers are, at least in that cohort, but also all of the asymptomatic cases put in there means, of course, the case fatality rate appears much lower. What I think, what these things do, though, is they actually detract from some of the really important issues that are behind mortality. And Archie alluded to some of these, in that, while we focus on, why is there a difference or why are these countries doing better, it's not because they have a magic bullet. There's no, COVID magic bullet treatment. That doesn't exist. I say that as a clinician too. It's a very difficult disease. But what we do know is that right across the world, there's not just an age bias, and the older you get, the more likely you are, but a very important gender bias. So in Britain, for example, the most recent data shows us that if you're a man, and you end up in ICU, more than 70% of those on ICU are men. And of those men, more than 50% will die, which is quite different to women. If they actually end up on ICU, only 43%. It's a huge difference, and we see that across the globe, across every different country, and we've seen that since the beginning. Originally, we thought, is it health-seeking behaviour? Do men smoke more? Don't they wash their hands? What's going on? But actually, it's really important to understand this. And conversely, why are women protected? Is it because they have a more robust immune system? Is that something that we can then harness? Because whatever's protecting you, we can use for treatment. So,
okay. Dr. Ali Umrani here in Doha, quarantining particularly blue-collar workers, I guess you would say that was the right thing to do at the right time, as soon as the Qatari authorities and the Qatari government switched on to what was really happening. However, the infection rate is still climbing. As of 2 hours ago, Johns Hopkins in the States is saying 17,142 cases here, mainly in Doha.
Yes, it is quite a challenging virus, and anyone who tries to tell you otherwise is probably misleading you. We're talking about a highly infectious virus with a large pool of asymptomatic or very, very mildly symptomatic individuals able to carry the virus and spread it at least 2 days, we know now, before they show any symptoms. So the virus is able to spread very, very quickly. I think that the numbers, in one way, are concerning, but at the same time, they're not increasing in a way that we might have seen elsewhere. The numbers are steadily increasing. I think this is the best that you can do with such a type of virus, with the contagiousness that I just described. If you're able to control and maintain the numbers that are coming through within those that the system can absorb, in terms of providing safe and appropriate isolation facilities and providing medical care for those who require medical care, if you're able to maintain it at that kind of level, then I think that's a measure for success. What Qatar has certainly been able to avoid successfully so far is those tsunamis of numbers that are beyond any healthcare system's capacity, numbers that are in the thousands per day that no system can really deal with effectively.
Okay.
So the response, I think, has been successful if you look at it from that angle.
OK, let's flip that around a little bit. Archie Clements in Perth, coming back to you. There wasn't a tsunami of cases, fresh infections, and the mortality rate is low in Singapore. There was, however, between a tsunami of infections and zero infections, the R number coming less than 1, there was a spike in Singapore, started on April the 12th. Why April the 12th? I mean, did the authorities take their eye off the ball? Everyone would, I assume, say no, they didn't.
Well, Singapore, I guess, is a little different, again, in that it's an international travel hub. And whilst the Singaporean government exercised or implemented a very effective public health response. Singapore sees a constant flow of people across its border. And so I think that's created a unique challenge for Singapore. So, I mean, if you compare it to Australia, we were able to shut our borders and very quickly eliminate new people travelling into the country. That was a little more difficult for Singapore. And then, of course, they've also got their large migrant worker population. And then once the virus got into that group, it tended to spread because that group of people tend to be housed together in larger groups, and transmission is facilitated. So Singapore does face a number of unique challenges. I think that relate to those factors, relates to it being an international travel hub, to having a high migrant worker population, and I think it's possible that in the early days of the epidemic, the virus hadn't yet, I guess, spread in those high risk groups, and Singapore had been able to get on top of it, but then things started to get away when the virus started to circulate amongst the migrant worker population.
Annie Sparrow in Geneva, coming back to you. I totally, of course, take on board what you were saying, that there's no silver bullet here to rid the world of coronavirus. It's here for the foreseeable future. It may become endemic. But is there another component that we need to talk about? And it might be this, that if it's Singapore or Qatar, those two countries, particularly Singapore, were praised by the World Health Organization for coming up with an all-of-government approach. And that approach works if you've got a small, wealthy country, a city-state like Singapore, country like Qatar, but you can't apply an all-of-government approach to Europe or to the United States. And that's why, say, in the US, you get mixed messages coming out from different parts of the government, different parts of the local government. And in Singapore, we didn't get that. And in Qatar, we haven't had that either.
Yeah, it does make it very difficult. And particularly then in terms of those of us trying to work, whether the clinicians trying to discover what are the effective strategies or what are the effective public health strategies. We all agree that we have to test in order to understand, not only to capture the cases, to be able to determine the case fatality rate, to be able to isolate, to quarantine, etc. But also to then, we have to employ these measures of social distancing, quarantine, etc. We know how to do those, it's clear. But in order to move forward, we actually have to now do what we're doing, which is to put in billions of dollars now in order to save trillions, because that's what it's going to take to restart the global economy. So without actually knowing what the population level of immunity is, we need to actually have tools in place that are going to provide both protection and treatment. And that then comes back to thinking about who does the virus target, given that the virus doesn't discriminate between with whom it affects in terms of age or gender or race or ethnic. It has a very different clinical outcome depending on your age, your gender, and the kind of the pre-existing health and economic disparities that already exist. And that's why, for example, in the States, we see this exorbitant burden on the African-American population, where they're dying 3 times faster at a rate 3 times higher than white population, and even more than twice that of Asians and Hispanics. What's that about? And that then comes back to the comorbidities. As far as I can tell, between Singapore and Qatar and the US and Europe, we all have pretty much the same top 10 causes of death, and those include cardiovascular disease, diabetes, hypertension, obesity, and being overweight in this disease is a clear risk factor. And then we understand that those are something to do with how the disease behaves. But if we all have the same comorbidities, then why is it we're getting these very different outcomes? And that also means being very thoughtful about, as Nigel said, like the immunology of this disease. Children seem to be protected. They don't develop clots the way that women and men do. And we see a trajectory in some of these which are going to guide our way forward in many ways.
OK. Just to pause you there, Annie Sparrow, because we are heading towards the end of the programme. Ali Omrani here in Doha. When you're talking to other clinicians, other people involved in this fight, answer me this. Why did Qatar not go for a full lockdown from the get-go? Because talking about the coronavirus and COVID-19 a lot here on Inside Story, it's clear to me that if you close a country down for 3 weeks, you can, quote, beat the virus in 2. So everything here in Qatar has been a strong recommendation. It hasn't been go home, stay home. You get 1 trip out the front door per day. Why did they not do that?
I personally think that when you're trying to ask people to do things that are very different to their norms, things that are different and are not easy to maintain, I think maintaining a reasonable middle ground between forcing people to do things that are completely intolerable, very, very difficult to comply with in the long term and may well lead to some kind of a backlash, versus allowing people to do everything without any controls. I think Qatar has managed to walk in the middle line very, very well, providing a lot of education, a lot of information to the citizens and to the residents of the country as to what they should do to try to prevent infection and try to contribute to the efforts for the control. Try at the same time to limit access to certain things like entertainment, for example, but allowing essential shopping and essential trips around. I think with that kind of effort, you're more likely to have people complying with the recommendations, and you're more likely to be more effective than if you were to force a complete lockdown. At some point, you're going to have to remove that lockdown. And when you do, there may be a second or third wave that may well be harder than the first.
Archie Clements, on that point of a second wave, how do these two countries fine-tune what they're doing if they feel the need to go beyond what they've already done if there's a second wave?
Well, I think it's really critical that the two countries that we're talking about take a risk-based approach and a phased approach, and that they don't rush into coming out of lockdown, and that they do it in a staged way so that they can monitor the impact of changes and see whether they result in a resurgence of cases, and good communication, making the population aware that if cases come back, that social distancing and other lockdown measures would need to be put back in place. You made a point earlier about the differences between centrally managed systems and more federal systems, and I do think that that runs the risk of giving a sort of simplistic impression of how different systems function and how successful they are in managing pandemics. I live in Australia, which has a federal system similar to the United States, and we've been incredibly effective in tackling the pandemic. And the reason for that is because we have very strong and collaborative leadership. Our government set up a national cabinet where the heads of all of the different jurisdictions, regardless of their political party, were able to come together and manage the pandemic or the epidemic at a national level. And I think that's really where the failing is in the United States and Europe, and that is around a lack of collaborative and open government and a politicisation of the pandemic, a politicisation of the response. It's not just about the political or governance system of a country, it's how that system is used to manage the pandemic. And
I just want to put the last question to Annie Sparrow in Geneva. Pardon me for interrupting you, Archie Clements. Clearly, Annie Sparrow, countries around the world are not as wealthy as Qatar and Singapore. Flexibility was something that we talked about at the top of the programme. What's the takeaway for you for other countries? What can they learn from what's happened here and in Singapore?
The reason we try so hard to flatten the curve is because it buys us the time to be able to manage these patients and not overwhelm our hospitals to the catastrophic extent that we've seen in Italy and in Spain. And not just our hospitals, our healthcare workers, because they're on the front line, and the greater the burden on them, and if we haven't got the PPE in place to protect them, then they're the ones who then get infected, and then we lose both the human resources and the physical resources to actually look after our patients. So it is incredibly important to actually put everything in place to slow things down, to allow that to be done more gradually. And it also says, look at your demographics. Where are the most vulnerable cases? If you have an elderly population, then figure out how to focus on your nursing homes fast. So you don't suddenly find, as we did in Canada, that there's this huge mortality rate in nursing homes because we haven't paid attention, because we're so busy thinking about what goes on in the ICU.
OK, we have to leave it there. Thank you so much to our guests. They were Dr. Ali Omrani, Dr. Annie Sparrow and Professor Archie Clements. And thank you, too, for watching. You can see the show again anytime via the website, aljazeera.com. And for further discussion, go to our Facebook page. That's facebook.com/AJ Inside Story. You can also join the conversation on Twitter. It's at AJ Inside Story. I'm at Peter Dobby1. From me, Peter Dobby, and the team here in Doha. Thanks for watching. I will see you very soon. For the moment, bye-bye.